will be arguing that the criteria are too liberal. I should probably begin by letting you know that I was a member of the panel that formulated those diagnostic criteria. Just by way of introduction, I would say that we do not have any specific tests for multiple sclerosis. It's a diagnosis that we make through a combination of mainly clinical symptoms and objective signs, as well as MRI findings. And we can talk in a minute about the fact that spinal fluid findings, which were part of the diagnostic criteria, were removed and have just been recently reintroduced in 2017, but in a somewhat different role than they existed before. So the fact is that most MS symptoms, or many MS symptoms, are quite nonspecific. Things like numbness, tingling, weakness, fatigue. The diagnostic criteria are fairly clear that we should be applying them only in situations where patients present with what is considered a typical MS syndrome. And that would be something like optic neuritis, where patients have acute visual loss in one eye. This would be certainly something very suggestive of MS, or partial transverse myelitis. But I would argue that many patients with multiple sclerosis do not present with such characteristic symptoms. And the criteria have never been validated in a general neurologic practice, where patients come with perhaps less specific symptoms, and nonetheless, neurologists will use these diagnostic criteria to make the diagnosis of MS. And they've been progressively liberalized over time. And in many patients, the diagnosis hinges on finding MRI findings that are typical of multiple sclerosis, but they've been liberalized to the point where only 2 lesions in 2 of 4 characteristic locations are necessary to be found. And the fact is that MRI lesions are very common in the general population. Patients with migraine will have white matter lesions. And there are some additional specificity features to try to improve upon this diagnosis. But the fact is that many patients who do not have multiple sclerosis may satisfy these criteria. And the net result has been that many patients are given a diagnosis of MS who do not have this condition. And in several recent series, it's been found in the United States. There was also a recent series conducted in Beirut and Kuwait. About 1 in 5 patients who are given a diagnosis of MS after a number of years are seen at specialty centers, and it's found that the diagnosis was wrong. And this really has major implications, because it's been found that the duration of misdiagnosis until a patient gets a correct diagnosis is often well over a decade. Many of the patients have been on one, in fact, many patients on multiple different MS disease-modifying treatments at tremendous cost, and certainly with potential serious side effects. And I think the psychosocial consequences of misdiagnosis are huge. Patients who are given this diagnosis often psychologically will believe that they have an irreversible, inexorably worsening neurologic condition. They may leave their job. And trying to take that diagnosis away after 10 years and saying, well, the good news, you don't have MS. Well, they haven't been working for the last 5 or 6 years. And what did they go back to? It's really a very, very bad situation. So often the diagnosis itself is even worse than the disease, just the psychological impact of being given a diagnosis of MS. So misdiagnosis is certainly something very important to avoid. And unfortunately, that's been one of the major prices that we pay for misdiagnosis. And I don't want to say that too liberal diagnostic criteria are the only reason for misdiagnosis. Certainly, if the diagnostic criteria are applied very strictly in the situation that they were intended, patients with a very typical syndrome of multiple sclerosis. But as I say, that is not the way they are often used in clinical practice. And I would argue that in those patients who have a typical clinical syndrome of multiple sclerosis, you almost don't need diagnostic criteria because the pretest probability that those patients will ultimately develop further symptoms that will lead to a diagnosis of MS is very, very high. Most patients with optic neuritis will eventually develop MS, and it's really not something that is very, very difficult if you've identified that the patient has a very typical syndrome. Where you need the help is in the patients who have atypical symptoms. And I think we do need a new path for that group of patients. I would say for diagnostic criteria in general, make criteria that are useful for most patients and can be used by general neurologists in their practice with a high degree of reliability. And I think that's what we need to work toward.